this is our schedule for our report out to attack time of 20 minutes. So I'd like to introduce my team, myself, Lori Friesen, John Piggott, Brian Harasmick, Stella Zinsi, and Cynthia Letitia. We also had some content experts that were very helpful to us, Tracy Hobson and Dr. Wessels. And our sponsor was Carol Gregorick. So our project, it was a very long title. We were looking at patients that have been harmed due to the delay in treatment, resulting in patients leaving the emergency department waiting room without being seen by a physician or being reassessed by a triage nurse within the CTAS timeframe. So our goal was that patients be seen within the CTAS timeframe. And the situation that brought this to us to do is because patients have been harmed due to delay in treatment, and patients are leaving the department waiting room without being seen by a physician or being reassessed by a nurse. And patients are waiting as well because of a backup in the system. So the reason was there was a number of complaints. There was 15 in a 11-month period of patients, and there's also some incidents. There was 10 from the same 11-month period. The other thing is we also had a provincial alert that helped set this in motion too, where in our health region a patient left the emergency room without being seen, ended up passing away. So, and one thing is our emergency room is quite busy, as everybody knows. So it turns out that we have on average 75 people coming to the emergency room, which works out to be about 27,000 people annually. And our biggest defect, one of the defects that we're seeing was we did another observation, and during a 2-hour period, the triage nurse was interrupted 85 times. So this makes it so that she can't see people.
This is our pre-Kaizen value stream, and obviously it's somewhat complex, but I want to emphasize to everybody here that from the period from triage to the patient in the ED bed, the waiting time is significant. It's almost 2 hours. We know that there's a lot of variability over the course of a day as well, but this particular time, again, shows a lot of time. And those starbursts up there on the left-hand side, patients waiting beyond CTAS time, patients leaving without being seen, the triage nurse interrupted and leaving the triage area, and also no visuals of the ER were starbursts that basically came to us in our when our team started to look at this mistake-proofing project. We also want to identify to you that our lead time was 112 minutes, non-value added time 94%, and so with a value added of only 6%. So again, it gave us some meat to work on. Okay.
So once again, the defect that we're currently addressing is patients leaving the ER without being seen. Our current state level of inspection was 1. No one was really tracking these patients that were leaving without being seen. Using data gathered over about a year, that worked out. We realized about 10% of people were going home without being seen by a doctor. In consultation with ER staff and doctors, we decided to implement 2 ideas. The first idea was the ER nurse will come to get the patient from triage rather than the triage nurse delivering the patient into ER. This is a pull rather than a push. The second thing we decided to try was we installed a doorbell in triage that is pressed when a CTAS 1 or CTAS 2 arrives. These 2 ideas were very briefly tested, but with very promising results. After implementing these 2 ideas, our new level of inspection we feel is a level 3, self-inspection with judgment. The new defect percentage is 1.6%, which is an improvement of 84%. Some of the defect data we gathered included a graph showing patients leaving without being seen according to CTAS score. From the graph, you can see 1s and 2s really aren't the concern. The concern of people going home is the 3, 4s, and 5s. In each instant, the 5 graphs add up to about the 10% pre-Kaizen that we quoted. We also made spaghetti diagrams. This was the pre-Kaizen spaghetti diagram. That's the triage nurse and all the trips and disruptions she's having traveling through the ER. We have a post-Kaizen spaghetti diagram. It shows far less travel. And the last item, the last bit of information is we created a Pareto chart showing all the disruptions of the triage nurse.
So this is our target progress report, and 3 things that really I want to highlight in terms of how patient safety was improved. And the one thing, of course, was the focus of our efforts, and that is patients leaving without being seen. So that was our defect that we looked at. And from the data that we collected, we saw that 9 patients leave without being seen per 62 visits. And after our PDSA around the pull system, the audio cue or the andon, which would reflect an abnormality and decrease in interruptions, the final was 1 interruption in 62 visits. So that was a reduction of defect by 88%. We also implemented or introduced standard work, and there was no standard work prior to that. So again, that was an increase of 100%. The other area where improved patient safety is around interruptions, and that can be reflected in the walking distance. So as Brian pointed out on the spaghetti diagram that was just shown, the pull system of having patients pulled from the back rather than a triage nurse showed an 82% decrease in the amount of steps and walking distance. So that allows the triage nurse to be in triage dealing with patients and taking care of patients. The third area is around the lead time. And again, with the decrease in the interruptions, the use of the andon system or the doorbell, that visual cue, and the pull system, the lead time has decreased. And so therefore, less time patients are waiting and less are leaving without being seen. So there was in the lead time an 80% increase. So how was this done? And we began with a number of ideas. And one of the first ideas that came up is around the pull system. So the charts are being picked up from the back, and patients are being brought in from the nurses that are in the back or the physicians as well. Charts are also organized so that they know which patients come in. The next one is around standard work, and that one also was something that was drafted and it will be talked about in a little while when we're talking about the PDSA. The next one is around decreasing the interruption and to provide some assistance with people that are going into the emergency department, family or patients. And again, the next one is around interruption. And lastly, one that is a next idea that we want to test, and this is something that Stan will talk a little bit more about, is the card system for patients, so that patients are aware what time they could be reassessed or expect to come into the emergency department.
Good morning, everybody. I see by our time we're way ahead of schedule, so I'm really going to have to slow down. I think we've cut our time by about 50%. So I'm going to slow down. So I'm talking about the PDSAs, and so we're looking at ER flow. For those that aren't aware of our system, we have a registration and triage out at the front of the hospital. Then you actually have to go through a door to get into the emergency room department. So there's kind of a physical space problem that way. So in the past, the triage nurse had multiple duties. They didn't just triage. They also went into the back and brought patients there and did some things there. And we wanted a more dedicated process for the triage nurse to stay at triage. Because part of the defect, there was often nobody at triage, so patients would be in the waiting room trying to be seen, but the triage nurse was doing other duties. So our first order of business was actually communicating our project to all the team members as well as all the staff in the ER, including the physicians. And actually that was very enlightening because they actually don't do we had several meetings with the, a couple with the ER utilization committee. We had 4 meetings with the nursing groups and 1 with physicians. So following that, we had an idea board, which you can kind of see there. So they actually generated lots of ideas. So this is about 18 ideas that they had, things that could be happen immediately and put into place. And then there was several that were going to be kind of long-term things to work on. So this is showing the ones that kind of we could do right away. So then we had further meetings with all the staff because we have to prioritize what are we going to do first. So it showed though that lots of ideas could be generated. This was over a very short time period. So one of the first things that we did with our ideas after we first met them, we were looking at putting in a pull system. So in the past, the triage nurse would actually take the patient into the back. Now what's happening is it's getting, so the triage nurse does the assessment. It goes on to Sunrise Clinical Manager, so it's on a board. So they can see at the back who's come in, what their CTAS score is. Then it's placed onto a chart on a folder on the desk. So when there's a room empty at the back, a nurse or a physician from the back can actually come up to the front, and they know where to look because they're in order of CTAS scoring as well as the time they arrive, so they can take the patient and pull them into the back. So that's the first thing that was implemented. When that happened, one of the things they realized, some people of course are much more urgent than others, so then they developed an and-on system. So they developed a call bell or a doorbell that they would push a button, and that would allow the staff in the back to know when there was CTAS 1 or 2 and they needed assistance, or if the triage nurse needed help for whatever reason, they would also push the button and then someone would come from the back to help. So that happened really quick. The next one that we did after that, and it's not quite developed yet, it's in the early stages, it's a card system. And this is a card that will be given to the patient, and what we'll explain is the CTAS guidelines will be on the card so the patient can see that. The triage nurse will explain that to the patient. They will write down the time that they were assessed and actually hand that to the patient. This is proposal, so this is going to happen. And then the patient will then take that card, and part of the thing is they'll be told that if you need to be seen within 30 minutes, so that if it's not happening, then they can go up to the triage desk and say, my time is up, I need to be reassessed. So hopefully people won't be falling through the cracks. Then what happens when they are reassessed, again that time can be written down and it'll go through until they're finally seen by the physician and the problem is dealt with. So it's going to do 2 things. One is going to be safety for the patient, because they're going to be reassessed when they need to be reassessed, but it'll allow us also to measure better than we currently do, because currently we don't have very good measurement system for all of these times. So hopefully it'll do both of those things. So that's that process. So then we also went into some standard work as well, because the triage nurse did many other things besides just triaging. And so one of the things we looked at is the flow in the ER. So now the triage nurse would hopefully be just doing triage. So they come in, they do their CTAS assessment, they post it. Then if it's a CTAS 1 or 2, or if the triage nurse needs assistance, they push the bell. Following that, then there could possibly be a time when they may have to reassess the patient if the patient has to wait in the waiting room for an extended period of time. And then the patient will be escorted into the back. So that's the first standard. So they didn't really have necessarily that standard work defined in the past. The next is standard work was for the, that's just showing, which picture is that?
Want the back?
Yep. So this is just showing after the triage nurses assess the patient, there's a holder on the desk, and they're placed in order of CTAS, higher acuity towards the front, and then towards the back is less acuity, as well as the time that they come in. Next slide. The next is the standard work for what's going to happen when the patient card comes through. So that's just showing that there would be a CTAS performed. The nurse would then explain to the patient exactly the process that's going to go on. They would give them the card, they write the times down. Then the patient would notify again if they have to be reassessed within a certain time period. assessment each time that happens, and then at the very end of that, when the patient has been seen, the cards will be collected, put into a box. They'll be collected daily. The data will be calculated weekly, and then will be displayed on a display board in the emergency department. And I think I stretched that out enough.
Thank you. This shows our post-Kaizen value stream. I want to particularly point out again that in the pre-Kaizen stream, we were looking at almost 2 hours of waiting time between triage and in the bed. With our new measurements, with the nurse pulling in the patients from the waiting room, with the use of the and-on, for this particular set of sample values that we measured, albeit it's limited, we were just under 15 minutes. The important thing is there, the non-value added time for the patient drives down from 94% to about 67% with waiting time. And we've also, at least in part, removed certain starburst ideas that we had, which are the patient leaves without being seen, then the patient is seen beyond the CTAS time, and also we have reduced some of the interruptions that pulled away the triage nurse from her important work, which is to triage the patients and watch the patients in the waiting room. So actually, for example, this is just one of our time observation sheets. Obviously, we did 5. It isn't a lot, but and again, one of the things I have to say is that one of the things about emergency is it's so variable, and it's so much dependent on when you do your timings. But having said that, we feel that certainly for that and-on and that nurse coming out definitely helps to reduce the interruptions on the triage nurse, and it is definitely helping with respect to those both inpatient patients who are leaving without being seen and those that are worsening while they're sitting in the waiting room.
So this is our newspaper. As you had seen, the staff came up with lots of ideas, and we ended up coming up with the 6 top priority ideas, and we did end up, and they also picked their one, which is the one that we started with. So there's quite a few that still need to be worked on, but there's a couple that, a few that we finished, and one was that partially the triage nurse is consistently interrupted. We had that 85 interruptions in a 2-hour period. And one of the things that was done 100% is that we closed those ER doors so that the people coming and going and talking to the nurse, and that was, so people don't go through those doors, they have to go through the main doors now. So that one was completed 100%. And then as we were talking before, the point number 5, it was the triage nurse staying in the triage room to do what she needs to do, and then the nurse or the physician are coming in to pull the people. And we're at about 50%, and we're hoping to get that fully implemented by the end of May.
Okay, just in summary, I think what we concluded, number 1 is that an emergency department is a busy 24-hour department with a lot of variability. It's hard to organize PDSAs and various improvement tests when you have, again, that 7-day-a-week, 24-hour-a-day system. And so bringing everybody to work on it is a challenge. We felt that it's important in a mistake-proofing process like this to try to narrow the scope to a manageable size so that you can make and see real improvements. We also found that it's important to break apart some assumptions, and you have to dig down to the root cause. Like for example, we assume that why do people leave without being seen? And so what we found we had to do was call a number of patients and ask why are they why did they leave? And again, most of them are because they just got tired waiting. So this is a small part of the patient flow. We feel that we need to fit in with other PIWs with respect to the ER, and we recognize and appreciate that getting staff and physicians involved is a very important part of our work.
And my job is to thank everybody, so I'd like to thank JBA for giving us the tools for our US tour, the result of VMI at Children's Hospital, for all the members of the teams that we worked with in the emergency department, all the staff there, for the nursing lead imagine Tracy, the physicians, Colin Gallins and Joanne Wessels,